I'm just so grateful that the guys that I sent text messages to, personal messages to over the last couple of weeks, I called you all my tribe because that's how much you mean to me. I sent out personal text and emails to about 125 men. So half of you at least took the call and said, okay, I'll sign up. You're going to get some interesting information, some facts. And at the end of this, you'll even be offered free prostate testing. You'll be offered a toolkit as well. HIV as well as COVID testing. We'll tell you all about that. Wanted to introduce you to a dynamic panel of doctors. Dr. Christopher Scott. Dr. Chris has been with me for a while. Dr. Christopher Scott has done a lot of the Tom Joyner, Take a Loved One to the Doctor Day, DREs. Guys, if you were with me then, you may not want to remember him because it's not a test that everybody likes. But Chris earned his medical degree from HU, Howard University, that is. He completed his residency in Emory. His bachelor's degree in biology is from the University of Virginia. He points out that during this time, he's got the art of time management has become very essential in his life because he's the current senior vice president for West Florida Division of Envision Healthcare, and he's done that since 2016. He oversees the physician staffing, quality, fiscal efficiency, but he's also on the floor. He volunteers in emergency rooms and he makes sure to maintain his bedside manner and he stays up to date on everything. And that's his philanthropic just donation back to health. Dr. Abraham Lincoln Woods is another dear friend of mine. He's been around for the Take a Loved One to the Doctor Day events as well, but he is also a very highly sought after and recognized urologist here in Orlando. He's a native of Birmingham, Alabama, a urological surgeon. He's had his practice in Altamont Springs for many years. As I said, a sought after teacher, I'll say preacher too. He's a surgeon and just a great doctor. He's an expert on prostate cancer, benign prostate enlargement, female urinary incontinence, and pelvic floor disorders, as well as many other urological concerns. His cancer concerns for both his mom and his dad caused Dr. Woods to take a new spirit and a new approach to traditional medicine and urology in his practice in Altamont Springs. How do I know? Once again, Dr. Woods is part of my medical tribe, at least for my husband, who is a prostate cancer survivor. Hence my interest, my genuine interest in today's discussion. I'm going to introduce you to Dr. Abraham Woods in just a moment. We also have with us today Dr. Dan Sperling. Dr. Dan Sperling, we met through Dr. Woods. I have been doing some research and ironically, one day we were coming to a Dr. Woods appointment and he said, guys, can't do anything else for you. You got to make a decision. And I got somebody that I think you may be able to, be satisfied with. And Dr. Dan Sperling is in South Florida. He's the leader in the detection of prostate tumors through the use of image-guided technology. Dr. Sperling developed the 3T multi-parametric MRI, the blue laser solutions. He specializes in magnetic resources imaging, or the MRI. That's what he uses for tumor detection, targeted biopsies, the guided biopsy, prostate mapping, and treatment. He's a member of the American Board of Radiology. Dr. Sperling serves as medical director and chief interventional uroradiologist at the Sperling Prostate Center in Florida and in New York, as well as the medical director of its parent practice, the Sperling Medical Group. He speaks nationally about prostate cancer detection and treatment. Most recently, he lectured to over 150 urologists at NYU at a conference for advances in prostate imaging. That's Dr. Danny Sperling. Dr. Robert Baker, another dear friend of mine. He's my personal doctor. He is my gastroenterologist. He's a board certified gastroenterologist with over 25 years of practice, a gastroenterology specialist of Orlando. Dr. Baker completed his undergraduate degree in biology from FAMU and his doctorate from the University of Florida School of Medicine. He went on to complete his subspecialty training in gastroenterology at Tulane University in New Orleans. During his fellowship there, he was accepted into the prestigious Musser Birch Honor Society. He treats a full range of gastroenterology conditions with advanced techniques, from routine colonoscopy procedures to minimally invasive hemorrhoid banding and treatment for conditions such as GERD, hepatitis, and irritable bowel syndrome. He's been a guest on several radio and television shows, mine included when I worked for a radio station here. So we're going to start this evening with Dr. Baker, and we're going to talk about colon cancer. So I'm glad that you were last on the screen, so you will be first up.
Thank you,
Colon
Monica.
cancer, yes, is the second leading cause of cancer deaths, with African Americans having the highest mortality. And because of that, Black men should be tested earlier. I wanted to share a quick PowerPoint presentation with you. I may talk a little bit through it, but let's share this with you. Hey, Georgie. So the first slide is going to take a look at your colon, actually. There are actually 4 segments, and the doctor's going to talk about the colon. If you look at it, you would, okay, we're talking about colorectal cancer in African Americans. You'll see this. The number 2 leading cause of cancer deaths, the 5-year survival rate after detection and treatment of early stage colon cancer is 90%. And the survival rate, if treated at later stages, could be 12%. Again, we know that Black people have the highest colorectal cancer incidence. The risk factors: 10.6% of African Americans are diagnosed with colon cancer before age of 50, compared to 5.5% of whites. Chronic inflammatory bowel disease, use of cigarettes. These are some of the risk factors. Your family or personal history, lack of exercise, and you'll see this throughout the colon cancer as well as prostate cancer. These are things that, healthier lifestyles, high intake of fatty foods, healthy options are perceived as even more expensive, and we'll talk about that too. There are some polyps here that Dr. Baker's going to go into, and we'll talk about the change in bowel habits that last more than a few days, but there are 3 types of polyps that come up, and early colon cancer usually has no symptoms. Okay. The change in the bowel habits lasting more than a few days, bleeding as well. Testing through the years can help detect precancerous polyps. The first year, you can do a fecal occult, that's the FOBT. By year 5, you should be doing a sigmoidoscopy, the double contrast barium enema. Year 10, you should be doing the colonoscopy, and he will talk about that as well. This final one is going to give you some information about something that I just mentioned to you all, and that is the fact that this Saturday, you'll be able to pick up your toolkits at Barnett Park, 10 a.m. to 2 p.m. You'll get a free screening, the PSA, COVID-19, and HIV. You can, if you've registered for your free prevention toolkit, that's the information down there. And it's just a way of saying thank you for attending today's webinar. So when we look at this, we go back and we say to Dr. Baker, how is this still happening? We think that we're in 2020. We should be further along. And Dr. Baker, you may tell me, are Black men getting tested more than before?
The answer is yes. The question is, are we making progress? The answer is yes. But I think with Chadwick Boseman's recent demise from colon cancer, it's awakened the reality of this disease to a lot of people. And I have a lot of phone calls now, a lot of people, young people who have questions about colon cancer. So we are making progress, but we're not making enough progress. And one of the reasons we're not doing that is because we're not getting tested. The colonoscopy is not being done as often as it should be in populations that should be tested. Now, there are a number of reasons for that. And if we want to really talk about why Black folks and Black men don't get tested, it simply comes down to economics. That's one reason. But Black men don't like to go to the doctor. I'll just be honest with you. And they don't want anybody touching their rear end.
Yeah,
it's as simple as that. There's also this misconception that maybe it's more important for women to get a colonoscopy and be tested than men. And that's not true. Actually, men have a higher incidence of colon cancer than women. In all races, Black men have a higher incidence than Black women. But what's disturbing is we're seeing younger individuals develop colon cancer in their 29 to 40-year-old range. It's still rare, but not unheard of. I've diagnosed colon cancer as early as 28 years old in a person that had no significant risk factors. And so one of the misconceptions is that if I had something growing in my intestine, then I would have symptoms, but that's not true. Most of patients with colon cancer have no symptoms until the very late stages. And you did show a slide, and I like to remind my patients that early and late have consequences for survival. Early, there's a 95% survival. Late, there's a 95% chance you're gonna die. Mm-hmm. So it's just like that for most cancers, the later the diagnosis. Now, colon cancer usually starts as a polyp, but before I get into that, what are the signs? You're not gonna have signs most of the time. However, you may have some bleeding, but usually that's late stage. You may have some pain, but usually that's late stage. You may have a change in your bowels, i.e. constipation when you used to be regular. That's late stage. Most patients who come in and we find colon cancer, they have no symptoms whatsoever. And they usually have a polyp, which is like a bump that grows on the wall of your intestine. The older you are, the greater the chance you're gonna have one of these polyps. And over 5 to 10 years, that polyp can degenerate into colon cancer. And the whole time it's growing, it causes no symptoms whatsoever. So if you're 50 years old, there's about a 30% chance you're gonna have a polyp. And if that polyp is not detected, then over the next 5 to 10 years, you can develop colon cancer. The problem is with African Americans, we've long known that they develop polyps at a much earlier age, maybe in the early 40s. The Cancer Society recommended 10 years ago that African Americans started getting their colonoscopies at age 45. However, the message has not been getting out to the public. And primary care, I think, have to do a better job of getting folks, especially African Americans, out to the gastroenterologist for colonoscopy. The information is not getting out there. But one of the big problems initially was, even though the Cancer Society said start colonoscopy at age 45 in African Americans, the insurance company said no. And of course, that's going to be a problem.
Right.
That's going to be a problem. Now, the Cancer Society says everyone should have a colonoscopy at age 45. However, I don't think there's any insurance companies now that will pay for white individuals to have a colonoscopy at age 45, unless there are certain risk factors like a family history of polyps or a family history of colon cancer or a genetic syndrome called Lynch syndrome. There are certain things that require you to have a colonoscopy at an earlier age. But keeping this discussion simple, the bottom line is most people think you're going to have symptoms. You're not going to have symptoms. You can get colon cancer before age 45, as shown by Chadwick Boseman. And economics play a big role, but there's a cultural problem with Black men going to the doctor. There's just no doubt about it. Mm-hmm. Black women in general, go to the doctor. Men, unless we see some bleeding, we don't want to go. And then there's
And you
this,
say by that time it's late.
it's too late. Yeah, by the time you see signs of colon cancer, it's too late. Then they have a test now called a Cologuard test. And a Cologuard is better than nothing. The problem, basically, it's a stool test that you mail in, and they look for abnormal cells, DNA cells that might have cells with cancer changes in them. And it's a pretty good test in the sense that if it's negative, then there's a 90% chance you don't have colon cancer. Okay. But that's a 10% chance that you do, and it was a false negative. But the problem with that test more than anything else is that polyps, which again lead to colon cancer, will only be detected about 60% of the time if you have a 1 centimeter polyp, which is a big polyp. So even though the test may be negative, you could have a polyp, and we know polyps lead to colon cancer. So the marketing for this is, you can do this instead of colonoscopy. That's not true. I tell people all the time, if you want to do something for yourself, you want to get rid of fatty foods, you want to exercise, you want to lose weight, you don't want to smoke. Those are things, and eat high fiber diet, fruits and high fiber foods. Those are some of the simple things you can do to decrease your chances of getting colon cancer. Obesity plays a big role in prostate cancer, colon cancer, endometrial cancer, et cetera, et cetera, et cetera. So we got to get some of this weight off. And we got to get rid of the sedentary lifestyle, which may actually be playing a role in the younger incidence of colon cancer. We have too many people sitting around now playing games, video games and so forth. And there's a thought that this sedentary lifestyle is actually contributing to colon cancer. It's an independent risk factor. There's a lot of studies that need to be done. But again, exercise, low-fat foods, high-fiber foods will improve your chances of not getting colon cancer. But remember what I said, age is the biggest risk factor. Once you hit age 50, there's a 30% chance you're going to have a polyp. Polyps lead to colon cancer. Once you hit age 70, there's a 50 to 60% chance you're going to have a polyp. So age, even if you do everything right, you still need to get checked.
Mm-hmm. And you mentioned these polyps. When you're getting the colonoscopy and your doctor does find the polyps there, are they going to remove them during that colonoscopy, along
Absolutely.
with hemorrhoids and other things like that? Are they going to do that then, or are they going to wait? Or how is that procedure?
Well, 95% of the time, the polyps are removed during that procedure. The procedure takes about 15 minutes to do. Now, one of the taboos of colonoscopy has been the prep. And I will tell you that you will spend some time in the bathroom, but a simple prep that I use is Gatorade with a powder mixed in called Miralax. And if you can drink Gatorade, you can drink this. It washes the bowel. This is the way I talk to my patient. It washes the bowel, get it good and clean so I can see what I'm doing. The previous prep was a salty, nasty tasting gallon of liquid that, it was disgusting. I'll be honest with you. But if you can drink Gatorade, you can drink the new prep, and it works very, very well. As you stated before, the polyps are removed. Over 90% of the time, we can remove those polyps. There are a few that are so big that we can't get out with the scope, or they're in a location that makes it impossible to remove with the scope. And if that happens, then you would need surgery. Again, even if you had a polyp with colon cancer, we can if the cancer is confined to the polyp, if we remove that polyp, you're cured. Simple as that. So early detection equals greater survival rate. Late detection, worse survival rate.
And it's as simple as that. I wanted to do something right now. I wanted to say to my gentlemen that are watching, and we have over 30 men right now, and we are recording this, is that if you have a question, put it in that group chat, and we'll be able to make sure that Dr. Baker can answer your questions. We're talking about colon cancer this evening, the risk factors and why you need to have early detection. He mentioned 2 types of tests, one that is a mail-in one that a lot of gentlemen who are I don't want to keep using the word fearful, but, we don't like going to the doctor.
Right.
And sometimes we're using that card. It's almost looking like a postcard, and we're sending that off to a particular company, and it's, research, or just, what's the word? It's just checking out what the stool sample is and letting you know. But he's saying you're going to have to get a more in-depth look.
That's true. Again, the basic screening studies, the Hemocoat card, testing for blood in the stool, is a simple thing that you can do. And in fact, you can order those cards on Amazon. And I tell some of my patients to do that. And the reason I tell them to do that is because we do colonoscopies every 5 to 10 years. The recommendation is you don't need one, but every 10 years. I tell my patients, try to get it every 5 years. And the reason is because colonoscopy is not 100%. Some of the polyps are flat. Some of the polyps are very hard to detect. They may be behind folds. You're assuming that the patient did a great prep, which is not the case a lot of times. And so you can miss these polyps. But however, knowing that polyps take 5 to 10 years to progress to cancer, usually, if you do a colonoscopy every 5 years, and luckily I haven't had a lot of complaints from the insurance company, we can catch those polyps that may have been missed early on. But the primary care used to do hemocoats in the office when you get your physical exam. Mine still do that, but a lot of them don't. So I tell my patients that even if they have a colonoscopy, order the hemocoat cards from Amazon, and every year do after the colonoscopy, let's say the second year, third year, check your stool for blood a couple of times, not just one time, but 2 times. Now, the downside to that, it's not a downside, but the caution is everybody's on baby aspirin now. If you do a hemocoat and you're on aspirin, your stools are going to be positive for blood. So they have to stop the aspirin if they're just taking it for prophylaxis. However, you do have some patients who have a cardiac stent. They can't stop the aspirin. So those patients, the hemocoat is not a good choice for them because it'll probably be positive. And then, what do? Well, you wind up doing another colonoscopy. So, but for those patients who are not on aspirin, who have had a colonoscopy and let's say 5 years ago, and you're just wondering, are you still safe? Just order the hemocoat cards on Amazon and at least do that.
Okay.
And if it's positive, then you go see your gastroenterologist.
Mm-hmm. Dr. Baker, we're going to ask some of these questions. One person, unhighlight that, please. Mr. Wall says, I'm going to see a colon and rectal surgeon tomorrow. How likely is it for doctors to refuse colon cancer testing on a 28-year-old? And you mentioned this a little bit earlier.
I think that, number one, unless there's an alarm sign like blood in the stool, something like that, or a strong family history of colon cancer, they're probably not going to do it. And I can't disagree with that. There are some cancer syndromes that genetic syndromes that put you at high risk for colon cancer, and those patients start getting colonoscopies at 25. However, if you've had bleeding, I don't think you will be denied a colonoscopy. But if you're just going because you want a quote screening study or a well-checked study at age 28, it will be denied, and I can't argue with that. I don't think it's necessary. There's more risk to doing the procedure than the chances of you having colon cancer. So why do the procedure?
Okay. The next question is coming from Mr. Young. He says, if insurance doesn't cover colonoscopies until a certain age, what's the alternative to culture testing, and what's the out-of-pocket cost?
Well, most of the insurance companies, Obamacare, that's one of the good things about Obamacare, is most of the insurance companies want you to get a colonoscopy. In fact, they send you a letter saying you need to go get your colonoscopy because they know it's cheaper for them to have a polyp removed or colon cancer at an early stage than late stage. It costs them a whole lot of money to treat colon cancers with the surgery, chemotherapy, radiation therapy, et cetera, et cetera. Out of cost, if you have to pay out of pocket, the total cost is going to be somewhere around $2,500 at an outpatient surgery center. That includes anesthesia, that includes pathology, that includes the doctor's fee, that includes surgery center fee, etc. However, if you do the same procedure at the hospital, it'll probably cost you $7,500.
Wow.
Everything is 3 times more expensive at the hospital. That's just the reality of the situation. Um, what was the second part of that question?
You answered both of them, the
Okay,
out-of-pocket
okay,
cost. Okay.
okay.
If you have had Mr. Morales ask this, hemorrhoidal flare-ups or some bleeding as a result in the past, can that lead to colon cancer?
No, hemorrhoids are independent of colon cancer. Hemorrhoids are managed one of two ways. If they are large, they're causing some frequent bleeding, you can get what we call a banding procedure in the office. That's only good for internal hemorrhoids. You can have internal hemorrhoids, external hemorrhoids. External hemorrhoids are only managed surgically. Okay, colorectal surgeons have to operate. However, nobody dies from hemorrhoids. Hemorrhoids have to be causing severe bleeding, leading to anemia, those types of things, before you would need to intervene aggressively with banding or surgery. Most patients have a little discomfort, maybe a little itching, that kind of thing. They can use Preparation H, Recticator, or a number of products over the counter. Hemorrhoidal surgery is probably the most painful surgery you can ever have. So that is only reserved for patients who are having significant bleeding, maybe requiring blood transfusions and that kind of thing.
Hmm. All right. I have a couple of other questions. What's the best Hemocult card to order? Mr. Young wants to know.
I think they call it the FIT, F-I-T, FIT 2. It's more sensitive, but just put in Hemocult card on Amazon and you'll see the FIT, F-I-T card pop up. And you usually want to get at least 2 because you want to check your stools twice at different times because polyps shed blood intermittently. So you want to, do it this week and then do it again next week. And if it's negative both times, then the chances are you don't have anything growing in the colon.
Okay. If you regularly get a colonoscopy, is it likely you will get colon cancer after the age of 70?
It decreases your chances significantly if you get them as you're supposed to. However, you do have to remember that colon cancers or the incidence of polyps increase with age. However, if you're getting regular colonoscopies, the incidence of colon polyps at age 70, I said was 50%. It'll actually be less than that. However, some of these polyps have spontaneous mutations and they can grow rather aggressively. And just because you had a negative colonoscopy at age 60 does not mean you can't have colon cancer at age 65. It's important that you check your stools for blood if you're not on aspirin every day. If you're on aspirin every day and you can stop it for a week, then check your stools for blood. The other thing you have to remember is that some of these polyps are very difficult to see. They're flat. So colonoscopy is the best test out there, but it's not a perfect test by no means. But just because you've been negative at age 45, at age 55, at age 65 does not mean you won't have colon cancer at age 72, for instance. So you need to stay in touch with your doctor.
Mm-hmm. Last question. If the client bleeds but has hemorrhoids, which may be the cause of the bleeding, would you proceed with testing? This includes a patient with a family history of prostate and colon cancer.
Absolutely. I can't tell you how many patients I've had that came in and they thought there was a little bleeding. And without knowing Chadwick's history, I would imagine that at age 36, when he probably developed a polyp and maybe saw some bleeding at 38, the thought was probably it was hemorrhoids, okay? The problem is whenever a patient come in to see me, even if they're 28 years old and they see some bleeding, it needs to be checked out. And I've had professionals here diagnosed with large polyps at 25, 26 years old, thought it was hemorrhoids. I've had patients with colon cancer diagnosed at age 30, 33 years old, many of them. And again, a lot of these people thought it was just hemorrhoids. Mm-hmm. Women tend to, if they see some blood, they tend to not assume that it's hemorrhoids. They go and get an opinion. Men tend to be more reluctant, especially younger men. Older men, if they see some bleeding, I think they're more likely to come in and get it checked out. But a 33-year-old that sees bleeding, a male, generally is a little reluctant. But to answer your question, even if you have hemorrhoids, even if we know you have hemorrhoids, unless you've had a colonoscopy within the last year or so, if you tell me you've had bleeding, you will get a colonoscopy. At least it will be recommended.
Mm-hmm. Last question, I promise. Is there a difference in issues if you have bright red blood as opposed to darker blood in your stool?
Well, yes. Now, we're talking about colon cancer. Bright red blood can be a sign of colon cancer. It does not necessarily mean that you have hemorrhoids, and that's what it's often mistaken to be from. All the darkness in the blood means is the longer it's in the colon, the darker the blood will be by the time it exits. So obviously, if you have a lesion, and let's say it's a polyp or even colon cancer sitting right there in the rectum, well, you're going to have fresh looking blood. So the color of the blood does not necessarily tell you very much. I will say that if the stool is black from the blood, it also can be a sign of colon cancer. A lot of people think that black stools mean there must be blood like an ulcer in the stomach. That's not necessarily true. If you have a cancer on the far side, on what we call the right side of the colon is 6 feet long. By the time that blood makes it all the way around to your rectum and out, it can be black and tarry looking. So the color of the stool has no significance as to whether or not you should be evaluated. Bright red blood should be evaluated. Maroon blood should be evaluated. Black tarry stools should be evaluated.
Mm-hmm. What's the contact information for you, Dr. B?
We're on 100 West Gore, and our office number is 407-245-3124.
To do that again, 245-3124.
3124.
And ask for my girl, Lisa.
That's right. Lisa's my nurse, been with me about 25, 26 years. So she will take good care of you. You can always go to my website, drrobertbaker.com. We have a lot of information on the internet about colon cancer, about acid reflux, about hepatitis, about you name it. We have a library of information. So feel free to check that out. Give us a call if we can be of service to you.
You were wonderful. Thank you so much, Dr. Baker. I know that you're going to get calls, and I just thank you for coming on to just answer some of these questions. And thank you, audience, for having so many very good questions for him. Thank you very much.
My pleasure.
Thank you very
much.
My
pleasure.
Thank you. Thank you. Thank you. Thank you. Thank you. Center for Change is who we're working with this evening in Florida Department of Health. But Center for Change, in conjunction with the Caribbean Health Summit, is offering every man on this call a free prostate exam this Saturday at Barnett Park from 10 a.m. to 2 p.m. At that time, you can pick up your toolkit that we've been talking about, these toolkits. You can also get a free COVID-19 and HIV test that day as well. So that's this Saturday we're talking about. The colon cancer screenings, you that Hemocult test that we were talking about, we won't have those for you then, but we do have information on how you can get those. Thank you very much. Someone printed up how you can get that on Amazon. That's a lot of good information. Thank you so much. I appreciate it. So we're going to go into part 2, which will be prostate cancer. We're moving along very well. So we've got we're at a good time pace too. We have 3 very special doctors up next to share on prostate cancer. It's that often dreaded discussion that men 40 and over have to have or should be having with their doctors. But before we get to Dr. Woods, Dr. Scott, and Dr. Sperling, let me also remind you that Center for Change will host 2 upcoming webinars on medication adherence and living with a chronic disease. They're virtual as well, and we'll keep you posted. We're going to share this PowerPoint with you right now. Gentlemen, it's time to know your risk for prostate cancer. Leading cause of cancer deaths. Number two, same as for colon cancer, most common cancer in men as well. African American men have the highest prostate cancer incidence. Risk factors, once again, 10 point, this is the colon cancer. We need prostate. Okay. Okay. Age, race. The two most common inherited syndromes, okay? A frequent need to urinate. Early prostate cancer usually has no symptoms. And again, just as in colon cancer, you often don't have the symptoms until it's late. A frequent need to urinate, especially at night, difficulty starting or stopping your stream of urine, a weak or interrupted urinary stream, leaking when you laugh or cough, inability to go to the restroom standing up. It could be painful or have a burning sensation during urination or ejaculation. You'll have blood in your urine or semen. And at that point, it's usually, like he said before, a little too late. Advanced symptoms, knowing them can save your life. If you have pain in the bones of those areas or stiffness in the pelvis, lower back, ribs, or upper thighs, loss of weight and appetite, fatigue, and sometimes even vomiting and swelling of your lower extremities. Those are advanced symptoms. The ABCs. DRE is that digital rectal exam that we told you about. It's done to determine if the prostate is enlarged and is either soft or has bumps or is very firm. That's called a hard prostate. And the PSA is that blood test you'll get that can indicate if you have a higher chance of having prostate cancer. But there are some controversies about that test, and we'll talk about that this evening. I'm reminding you that this Saturday, the 26th at Barnett Park from 10 to 2, you can also get free screenings for PSA, COVID-19, and HIV testing. So thank you very, very, very much. We're going to talk with Dr. Christopher Scott first. Dr. Christopher Scott is the gentleman that would be like your referring doctor. You would see him in his office, or if he were to be in the emergency room, say if it got that bad. I wanted to talk with you, Dr. Scott. What's the conversation that you typically have with men, especially brothers, when they come to your office? Do you ask them if they've had a prostate exam? Unmute. Okay. Do you ask them that question?
Yeah, absolutely. I primarily work out of the emergency room. So some of the common signs that I'll see are the frequency, the hesitancy, or I'll see males getting urinary tract infections, which is actually fairly rare in the male population, especially when you're getting males 40s, 50s get UTIs. So I'll have that type of conversation. Are they seeing blood in their ejaculate? Are they getting up frequently at night, in the absence of other things like diabetes? And I'll actually offer them the tests. Just as Dr. Baker alluded to, there's a cultural kind of repugnance to males going around the anus, especially in the people of color. So, they usually feel more at ease when they have another person of color, and we kind of have that conversation of the risk factors and things like that. So, once I do that, and if I feel it's something that's enlarged, if I feel bumps, as you say, or a woody sensation, things like that, or even tenderness, because I'll get a lot of these younger cats that get frequent episodes of prostatitis, and then I'll be referring them on to people like Dr. Sperling and Dr. Woods for further evaluation. So that's usually where I start the process, trying to throw a wide net.
Trying to throw a wide net. What's typically the age for prostate cancer testing to begin?
Yeah, same thing. I like to get them in at 45. Sometimes I'll even try and get them at 40, especially in Caribbean men. There's been some associations with the use of ackee in the Caribbean and some West African countries having high instances of prostate cancer. So definitely once they're in their early 40s, people of color or Caribbean, West African, I start referring them over.
Now, when we talk about people from the Caribbean being here in the States, are they prone to fear as much as African American men, or just the displeasure of having the exams done?
Yes, yeah, absolutely. It's just a mindset. It's a mindset that we have to educate on and get people used to the concept of getting tested and having people around the rectum for medical reasons. So that's the cultural thing that we have to overcome. Absolutely.
Mm-hmm, mm-hmm. So, if you were to say, when we talk about the disparities in healthcare, the typical man may not be able to afford that prostate exam, the total DRE, or even the PSA. What do you say? What do we do with men who, for financial reasons, can't get to a doctor?
So, well, the first and foremost is somehow we end up being the catch net in the emergency room for a lot of socioeconomic reasons, due to certain EMTALA regulations, the lack of ability to ask people for co-pays. The emergency room becomes the default. So, believe it or not, there are times where I'll actually order the PSA. As I said, I'm performing some of these primary exams just to get them started. And unfortunately, I get repeat visitors in the emergency room. So I'm able to start tracking or have my colleagues say, just take a look at this in a couple of days and get them a call back. After that, well, that's where I have to depend on the outpatient colleagues. And again, as alluded to, the insurance in this country is really has some challenges as far as getting people of certain socioeconomic classes the proper care and the proper early detection. So, again, as alluded to, if you're talking about people in the early 40s, outside the realm of severe risk factors, it does become a challenge. It does become a challenge. That's where places like Center for Change, that's where certain other groups really help tie us into some of the resources that are out there.
Mhm. I'm glad you brought up Center for Change, because I just wanted to give them another shout out. They were with me every year of Tom's Take a Loved One to the Doctor Day, and they are continuing to provide free testing in the community along with the Caribbean Health Summit as well. Is the rectal exam still effective? That is one question that has come up. I'm going to get your take on that, Dr. Scott, and then we're going to move over to Dr. Woods to get his take on that, and of course, Dr. Danny as well. But Dr. Scott, there is some controversy about that test. The other question is the rectal exam still effective? And then the next one is, it is my understanding that there's a less invasive test that's being used, such as a urine test. How effective is that? So, you know what I want you to do? I want you to deal with the rectal exam. Is that still effective?
So the answer is yes, especially in combination with PSA. I mean, these are early detection things. They're not necessarily as sensitive in some cases because there are certain areas of the prostate that can be missed. That's why you want to do it in combination with PSA. Some people are using earlier cutoffs on the levels, 2.5, and we screen that, and we're looking for changes. We're looking for the deltas, and comparing how one number is there a change in elevation to the next number. And again, that's where I start to refer them over to the Woods and the Sperlings, for tracking and those other more sensitive tests that they would do.
All right. Thank you very much, Dr. Scott. How do we reach you? I know you're with Envision Health. What is the best way to reach you if we had more questions?
Sure. So what I'll do is I'll leave my contact information on the post board. Again, I work in the emergency rooms, the HCA facilities around Central Florida and on the west coast of Florida, Tampa Bay, Pinellas County. But you can get any of my colleagues. Emergency rooms are 24 hours, and at least if you're in a dire strait, you can come in and get 24-hour, 24/7 healthcare.
All right. Dr. Scott, always my man to be able to be there for me to answer some questions. Thank you so
No
much. I
problem.
really
Take care.
appreciate you.
You
So
got it.
Dr. Baker gave us information that we needed, gentlemen, on colon cancer. And then Dr. Chris Scott, he would be your frontline doctor. He's the emergency room doctor that you would come to if you have an issue, and he would be able to do that testing for you, give you your results. Now, if you need further care, you would see a Dr. Abraham Woods. Let's go to Dr. Woods right now. Dr. Abe Woods, thank you so much for sitting with us this evening. I appreciate you as always. He has such a commitment to this community. He has worked diligently with Dr. Angela Adams with the Black Men's Health Summit for many years. And that came from a conversation that Angie was having because she was seeing just too many Black men receiving medication or whatever the case may be for prostate cancer. There had to be a better way to do it. So we began to invite men, all kinds of men, basically 35, 40 and up, for a day of free screenings. And that was a baby of his. Dr. Woods, thanks for being on this evening. We appreciate you. Love that smile.
Well, thank you. Can you hear me okay?
Yeah, I hear you fine. Now,
Good,
as a
good.
specialist, Dr. Woods, are men referred only, or can they come on their own to see you? Do they need a referral, or can they make their own appointment?
Well, Monica, before I start, let me just say a correction to you as to how I
Uh-oh.
got involved with this screening. And we're celebrating, I think, 2 years since the passing of Angela's mother.
Mhm.
Angela Adams' mother, Dr. Adams' mother, was the angel on a ship that talked to her daughter about her boyfriend who had passed away from prostate cancer and never talked to her about it. And her cry to the atmosphere at that time was, we need to talk to our Black men because many of them have this disease and are not getting early detection. And therefore, Angela, having seen me on a national platform for the American Cancer Society, came to Disney and saw me with Mr. Milken and a lot of national speakers, and she invited me out for tea. And after the tea, I said to her I would be committed to helping her get the funding for what she needed done. But speaking to the issue of prostate cancer and early detection, as I've gotten older in my years, I've grown away from tradition.
Mhm.
As you've heard Dr. Scott talk about tradition with the blood tests and also the rectal examination, the American Board of Urology holds us under handcuffs as to who we screen and why. When we started the summit, we were seeing people even as young as 32. And quite frankly, with some of the projects that we've had ongoing, like going over to Dominican Republic and Puerto Vallarta, Mexico to do HIFU, which I was one of the original people doing that over 15 years ago, we had young people going for different alternative treatments, such as HIFU, which is high intensity focused ultrasound, which was something that's now been approved for treatment of prostate cancer, well, treatment of prostate diseases in America today. But in regards to the early detection and screening, we are bound by regulatory bodies now to state that clearly 55 to 69 is that number that we have to look at. And why that's so important is that we have found when we do screenings on populations and we find positives, what have we done for that population? Because as you mentioned earlier, and Dr. Baker alluded to the fact, having access to healthcare is a very difficult problem for a lot of people. We can have access to healthcare and do treatment diagnoses, but once they're diagnosed with a devastating disease, what is the cost and financial note to that family as to survivability? Because we're talking about most times the head of a household. So what we do now is, and Dr. Scott alluded to you alluded to the fact, a new way of testing for prostate cancer, which is not a new way. It was through work with Angela, Dr. Adams, and the summit. We were able to get money to do a research project. And the simple project was this. we're seeing Black men with PSAs that are normal, and still we're finding prostate cancers. So how do we find that population? In the literature was not supporting us with what to do. So the PCA3, which is a genetic marker that we find in the urine for prostate cancer cells, we were beginning to look at our urines and have those done by a special lab, to the point that we did studies comparing digital rectal exam, the biopsy of the prostate with PSAs, to understand thoroughly how do we find early disease. We were finding people with normal PSAs and high PCA3s on an average of most of our minority men, which led us into a different movement. And that is what I've been doing for 20 years, even if it's not been approved by many insurance companies, is to test the urine. Fortunately, today, we've moved to a movement where my office, we shifted to genetics more so than doing the PSA routinely, which we still do. But with those genetic markers, we've been able to pick up cancers, even in some cases where a gentleman may have a normal PSA, normal rectal examination, but the caveat has been his family history, and also the other caveat in the literature, high risk factor, which is not just fatty foods, but a metabolic syndrome where waist over 42, diabetes, hypertension, and high triglycerides have been those indications for high-grade disease, and has proven out even today. So now we're doing blood tests in the office where we're looking for the BRCA, we're looking for other hereditary markers for mutations. And so in our office, we're the only setup in Central Florida where you can go to a monitor and put your family history, and if you qualify, you get free screening for those genetic markers. But why that's so important is that the new day for how we treat diseases has to have a lot to do with DNA. What you've seen recently about DNA is simply the play between politics and science. That has to do with, you hear all this thing about COVID-19. COVID-19, when you think of SARS and we think of mutations in regards to viruses, these mutations also occur in human beings and give rise to different types of prostate cancer or breast cancer or colon cancer. And Dr. Baker would probably agree with me. We're looking at genetic markers more and more. But what we don't hear a lot of with this new pandemic that's going on is we found a very important secret as far as decreasing prevalence, and that is changing lifestyle and diets. And that's one of the things that you probably learned from me and your husband, is that I'm a steward of lifestyle change. Why? When I had my parents with metastatic cancer, which I talk about often, my mother had metastatic breast flunking everything under the sun, and lymph nodes and cancer growing out of her neck and her back. 6 months to live. Dad had the worst cancer, non-small cell lung cancer with mets to the liver. And he was pronounced not treatable. No one would give him radiation or chemo. But they came to my office here in Altamont and said, we gave birth to you. You're a blessing from God, and you're going to keep us on the planet. Oh, boy. Now, I had to go back to my old school of research and find a cure for my parents. And it was through changing lifestyle and putting them on things that would help the body focus. Bodies that are basically alkaline, bodies that get away from acidity, bodies that are balanced, don't get cancers, they don't get even illnesses. And that's one of the things I had to do for myself and for my father and my mother. And lo and behold, 9 years later, Dad has a heart attack from something unrelated to cancer. And my mother, who was married to him for 60 years, decided, if my mate is gone, I have nothing else to do. And 7 months later, she passed away. So that's the good news, is that the cure for what we're talking about and prevention is right at our lips. It's called the mouth. And having to look at what we eat, how we live, more than just the fatty foods, because I've become now a very skeptic about simple things like eating a lot of fruit. Fruit has a large molecular structure called fructose. It does a lot of damage to the body, especially the human body, when we consume it. And a lot of the research and things I've exposed you to, like the work of Dr. Colin T. Campbell, who wrote, his book was the China Study, a very prolific work from the university, from Cornell University. But when that book came out, they all but threatened his life because he showed that he could reproduce the diets that we were eating and therefore grow cancers in normal mice or normal rabbits, reproducing this with a Q factor that was very low and significant. And then the next one was a cardiothoracic surgeon from Loma Linda, Dr. Steve Gundry, or he's my other reference that I quote that's easy for patients because his book's on diet of revolution, and then the last book is called The Plant Paradox. I have my patients to read these books because they talk about ways in which we can modify what we consume to decrease any type of disease, especially cancer. So I've been here for since 87. I used to do maybe 5 to 6 radical prostatectomies a week. Today, I can tell you over the last 15 years, I don't do any, pretty much zero. I've used alternative treatments, such as using the work of Dr. Sperling. And hello, Dr. Sperling. I get to meet you personally. I've been studying his work and looking at his results from other patients. And therefore, what I do as a physician, I look in the literature for what cutting edge treatments are available. I get my patients to those sources. When I was doing HIFU, my patients were paying to go overseas to get those sources. Do I feel like radical prostatectomy and radiation are the top cures? No, because the thing about it is you have to get control of these tumors, because when we look at the research and look at recurrence rates for these tumors that we've treated, it's not a good look. But when we look at what we're achieving with things called active surveillance, I can show you in my practice people that were written off with stage D prostate cancer that are living healthy lives, but they've changed how they live those lives, where they're not running to the grocery store and buying all those things that are out there appealing and staying very much away from carbohydrates, which is something that really we have to really weigh and look at the damage that we do to this earthly body, because we shouldn't be consuming those things in large amounts. I will stop here and leave it to you, and Monica, because you told me I was a preacher. And so I'm going to stop my sermon, all right, so that we can stay on time.
I just love sitting at your feet and learning from you. I really do. Gentlemen, you may add into the chat room whatever questions you'd like to have for Dr. Abraham Woods. How many men, Dr. Woods, come in to your office in advanced stages of cancer, having just not had that prostate exam, even, like I said earlier, in 2020?
Monica, that's a very good question. And my answer is, congratulations to society. The death rate has changed. It's decreased. We're, as urologists, we're not seeing stage D presentations as we used to. It used to be an every week occurrence when I started out in urology. Now we're not seeing stage D because people are doing the things for change. Lifestyle changes, exercising, eating properly. And I have to say, I'm very proud of the fact that I came through 20 years of a health summit with Dr. Adams, and it taught me something very important, because I thought the Tuskegee syphilis study had crippled Black men for life. But when you see thousands of men get up on a Saturday morning and show up on time and stay the whole day, and that project went on for 20 years, and we did over millions of screenings and exams, it shared to me these Black men are willing to do the right thing, to come and learn about their health. So education is important, whether you do it at church, whether you do it at the lodge, whether you do it at the fraternity house, whether there's infomercials to talk about it. These men are out there looking for answers, and I applaud them, Monica. I applaud them, because the death rate for the prostate cancer has decreased and is not as high as it used to be. Now the rate for something we call COVID is higher than what we used to see each year in prostate cancer. That's the sad note, because now you see the problem. It's not just black males, it is who politicize science. Now I've been demoted as a scientist, and I can't get people to do the right thing for a simple virus you can't see called COVID. Think of prostate cancer, a simple attack, silent attack, and look at the play down. So if we can get more education like you're doing, more structure, more understanding of what we should be eating out of the grocery store and what we should be doing when we have free time versus sitting down watching a movie or doing the little sedentary things and being very active, that's my conversation. That will change America and the world.
Mm-hmm. Again, I wanted to say thank you to all of the men who have joined us this evening. Continue to put your comments in the chat group. We'll make sure that one of the doctors answers them. Again, if you're just tuning in, and we have many men who have stayed with us throughout this entire time, and sometimes that's hard to get guys or women to do in a webinar. We've actually been on for 60 minutes now, and we just have one more doctor to get to. But we're not done with Dr. Woods yet. I wanted to make sure that, no, not done with you yet. I wanted to, again, reiterate to the gentleman, Dr. Woods, the right age to come in to have that prostate exam done, whether it's going to be DRE screening, whether it's going to be PSA or urine when they come into your office, whether they can walk in on their own, do they need a referral, and how do we reach you? That's a lot of questions.
Well, I know. But Monica, look at it this way. As I said, my board of urology, which I'm still board certified, creates guidelines. And one of the things we used to do as minority urologists, we used to raise a lot of headache about starting our screening at age 40. That is doing a digital rectal exam and even just a simple PSA, a blood test. But since we have looked at research and scientific data to say, look at outcome and look at measurements, we can't really push that number like we used to. This is what we push. If there is a real family history, your father, say brother, grandfather, his brother, your mother has breast cancer, or you take a genetic test, blood test, and you end up with mosaics, we have to screen you. We can show your insurance company that you are at risk for developing this disease and therefore put you through preliminary tests. If we cannot prove that and therefore say, oh, because I'm black and I just want to have my prostate examined, I need to sit with you and give you informed consent. Now the government and the committees in my board makes it very uncomfortable for us as we get reviewed for why we do invasive things when the age group does not recommend, when they don't recommend it according to how they look at statistics and review articles. And the most important factor is the review articles have come up with numbers like they said 53, now they shift 54, now it's 55, and we're supposed to stop doing routine exams at 69 because at that age we say we have these indolent tumors or small tumors that will not really take out a person's life, which we most commonly see. How we get to those numbers is when we look at England, they don't even screen for prostate cancer. Their rule is prostate cancer normally is a natural tumor that usually doesn't take anybody out. More men will die with it than from it. And therefore, when we look at the world literature and you look at numbers, we have done, when we look at statistics, we have more men that may have been made crippled from our aggressiveness. Say a young 32-year-old found to have prostate cancer. I can tell you, under doing trauma surgery at the University of Alabama, and we get these surprise autopsies on young trauma victims, there's prostate cancer foci that are found in those prostates that may not have done anything for that person. We have no idea. And so we have to pull back and make sure that we're doing something and we give you informed consent. I have to tell you what the test implies. I have to tell you what the outcome may imply. And even when we give you informed consent, it's up to you to decide if you want to take that risk to have a digital rectal exam and a PSA. It used to be easy. We would invite you to the thing, do the roundup, do the studies, but we got to have a plan of action. If your test is positive, what do we have in our hands that we can offer you so we haven't created any negative impact upon you for offering this test? And that is what the law looks at, because when we invite you to harm and leave you there, and you say, oh, no insurance, you got a bad cancer. We found it. So who's responsible? So our board is very clear about how we handle that. We have to make sure the person is aware and is informed. But if you want to know more information about this, you can find me at bestfloridaurologist.com. All
Okay.
right. Or if you're
BEST.
interested in other things that we do, you can find me at what is it? greatsexmd.com. And I'm the man for you to talk to you about those variables, because this is what we do. We help men to become healthy. My job as a urologist and board certified, yes, we do a good job of that, but I examine you from head to toe, because treating this disease is treating the whole patient. And therefore, a man has to be in, he has to understand what's going on with his whole body, not just the prostate. And so what I've learned in my practice is when I can treat and talk to the whole person, I get a better outcome,
Mm-hmm.
because people have to be responsible for their actions, including the diet. And Monica, you know, for one, I'm very strict about that when we're treating this disease, because I have seen people walk away from this diagnosis by reversing the pathology, and that's known in the literature. And
Mm-hmm.
it's surprising to me, because the first person that approached me about this was 40 with a PSA of 5. The normal is anything less than 4. He was 40, and 5 was very high for him. His biopsy was positive with cancer, but he said, I've been reading about nutrition. I'm going to do this, doctor. You can say my doctor, or I'll find someone else. I stayed the course. And today I can say, his kids are all grown, finished college. His PSAs are 0. I never touched him with a knife, because he's been holistic. He's been very functional. And that's the joy that I see. I mean, like myself, I'm approaching the 70s, but at least my PSA is zero point 0.5. I've never had any medical issues. I don't take any medicine for any medical, because I've learned that my mouth can be my best thing for cure of anything. Start there first. Look at what we eat. Obesity, our number one health problem in the world. Obesity, look at the people that died initially from COVID. Look at our young people who will die from COVID, because their immune systems are not built, because we vaccinate. They don't eat good diets. And this is one of the things I stressed during COVID. Eat appropriately. Eat those things that will stimulate your body to respond to your immune system. And that will keep you from getting any type of disease, including prostate cancer.
All right. Thank you very much. Dr. Baker mentioned that foods with high fructose content include melons, plums, mangoes, grapes. I love grapes.
Leave them
Oh,
alone.
okay. All right. They also cause a lot of gas and bloating, he says. Oh, okay. All right. Dr. Abraham Lincoln Woods, thank you so much for blessing us this evening. We appreciate you. Do not go anywhere if you don't have to, because we want to give gentlemen a full opportunity to ask any questions that they may want to. Dr. Danny Sperling is down in Delray Beach, Florida. Is that where? Yeah, and in New York City. He's a leader in the detection of prostate tumors through the use of image-guided technology. And we didn't talk about the surgical process with Dr. Woods, but sometimes men are afraid that the surgical process will leave them impotent, will leave them unable to urinate properly. It may leave them worse off than before. There's so many reasons men put off once they know that they have a high PSA level. They just put off going to the doctor. Dr. Sperling, as we mentioned, developed the 3T multi-parametric MRI, blue laser solutions to all of that. Dr. Danny Sperling, thank you so much for sitting with us this evening. What is it that you do in your office that is so different that Dr. Woods sent my husband to you?
Yes.
And it made a difference in our life because you saved his life. You two gentlemen saved my husband's life. Dr. Sperling, what is this 3T all about?
That's very kind of you, Monica. Thanks for having me here. And it's really an honor to be here with Dr. Woods, a pioneer in BPH treatment and treating large prostates. He was one of the first ones, physicians to encourage people to take medications like alpha blockers while everybody else was getting surgery. He thought outside the box. And I think that's an important approach in terms of diet, lifestyle change, modification, as he's talking about, and not running to do surgery and over-treating and causing a lot of side effects on a lot of men that are suffering or being diagnosed with prostate cancer. What I do at my center is we use MRI. It's the central focus of our diagnosis detection of prostate cancer. What we're using is the newest artificial intelligence programming. So not only are we using the MRI now for men who have elevated PSAs, they have suspected prostate cancer, we can use the MRI then to process the imaging in a unique way and see if there are tumors and detect them and see if men don't have tumors and then prevent them from going to an unnecessary biopsy, which can cause also side effects and infection. So the idea is first to even detect or prevent men from getting unnecessary biopsies. It's interesting, in the African-American population, there is a much higher incidence of death from low-grade or the slower-growing prostate cancers, which is interesting. You would think it would be from the higher-grade prostate cancers, but with low-grade prostate cancer in African-American men, the National Cancer Institute and some other studies have shown that they have a higher risk of developing tumor in what's called the anterior transition zone, the front of the prostate gland. That's an area that's actually not able to be palpated on a rectal exam. It's located far away from the rectum. And one of the only accurate ways of finding it is actually to use the MRI and to target it and to biopsy in the MRI machine itself, which is what I do. So that is one of the more common tumors that are missed by traditional methods. Additionally, the other factor that was found is African-American men have a higher incidence, like I said, of lower grade prostate cancer, slower growing. But what a lot of people are still not doing today is when they do a biopsy and find tumor, is to do what's called a genomic analysis, which Dr. Woods was also referring to. So you've actually got to look at the DNA of that tumor sample. It may not, just because it's a low-grade score, what we call the Gleason score, it's a low-grade score, doesn't mean it's not a faster growing tumor, more aggressive. So the genomics can actually highlight that and give you more information and decide on treatment when you might do active surveillance instead of just watch it. So it's important to differentiate, find the tumor, accurately diagnose it, and then you come to treatment and what types of treatments you could do. You could do active surveillance, watch the tumor with periodic biopsies. Surgery or radiation are the things that are used most commonly. Of course, everybody is aware of all those side effects that you were both mentioning before, such as erectile dysfunction and incontinence. I use focal therapy. It's a treatment of tumors inside the MRI where we use heat, either in the form of a laser called focal laser ablation or high intensity focused ultrasound, another technology Dr. Woods was mentioning, where we heat or destroy the tumor inside the MRI, which allows us to preserve the nerve tissue, preserve the rectal tissue, and prevent a lot of the side effects that are very common. Protect the external sphincter, and I've done now close to 2,000 of these laser ablation procedures, and no one has had incontinence and loss of urinary control with it. So we've really had wonderful results. In terms of screening, the most common method of screening to date are a lot of these PSA tests, blood tests using, there's other things called liquid biopsies and things like that that are being done, but we're using a newer type of MRI. It's called biparametric MRI screening, where because we're using this new artificial intelligence platform, we don't have to give dye or contrast, and we can use this 20-minute scan, screen the prostate for tumor if people have elevated PSAs, and then try to rule them out. It's a very non-invasive, accurate test. In fact, we're doing a study now where we're offering 100 screenings or free screenings to people with potentially elevated or normal PSAs. And we're trying to move in the direction of mammograms. Women get screened every year with mammography. Why can't we do what we call a manogram? You get men screened yearly with a non-contrast, non-invasive examination like the MRI. I mean, that's something else that we're trying to encourage and to study the utility of.
You know what? When you mentioned mammogram, I mean, I got excited. You know, no, you look at me funny, Abe, because I think about how invasive breast cancer can be, and what if there were a way to treat it the way yours with the focal ablation? That would be easier, maybe save more of the tissue and not be as devastating. I don't know. It was just a thought that I had. It's like, you know what? He's like,
you're
yeah,
actually onto something, Monica.
not.
Yeah, I mean, it's exactly why we developed focal therapy. If you look at a lumpectomy in breast cancer, right, the whole breast used to be removed, the full mastectomy, and the idea was, why can't you just remove the tumor and add some radiation instead of doing something so drastic? And that's where the concept of focal therapy came out, and it's called a male lumpectomy, right? It's very similar to that approach.
So I wasn't too far off for a DJ, huh? So, Dr. Sperling, what are the chances for healing or just better health? Is there a difference between the focal ablation and the more traditional way of treating tumors in men?
Well, yes. If you look at their traditional treatments, there's surgery where you cut out the whole prostate, called a radical prostatectomy. And then there is radiation therapy where you blast the entire prostate gland with high dose radiation and destroy the entire prostate gland. Those do carry risks. The radical prostatectomy, there is a significant high risk of incontinence, losing control of your urine flow. There's also a very high risk of losing erections, or erectile dysfunction. Radiation carries a risk of potentially causing a secondary tumor of the bladder. You can cause a new tumor of the rectum. They're both near the prostate, so the radiation can cause that. It does cause erectile dysfunction, but a much lower incidence of incontinence relative to the prostatectomy. So, those treatments are, in certain patients, they are indicated and they need to be used, but you've got to, it's not something where every male who has a prostate cancer, you should immediately jump to cut out their prostate. You're going to cause a tremendous amount of side effects, and most studies have shown in the long-term data with thousands of people that it doesn't really significantly change the mortality rate. You're not saving people's lives by over-treating and cutting out every male's prostate. Just like Dr. Woods was referring to, patients who have trauma and they do incidental, when they pass away, they do incidental autopsies. Most men have some form of low-grade prostate cancer. They don't all need to be treated. So the key is to first diagnose the cancer, find out exactly what kind of prostate tumor it is, if it requires some type of treatment. And then if it does, pick the appropriate treatment, and you start with the least aggressive means, which could be focal therapy, where we just treat the tumor and not the entire prostate, preserve erections, preserve a man's ability to control his urination, his quality of life. And then you can move on with the more aggressive tumors to other types of treatments. Mm-hmm. So staging and diagnosis is a critical piece of this. And that's where the advanced diagnostics come in with MRI, artificial intelligence, and some of the newer technologies that keep evolving.
Let me do one question from just out of, so the men can hear this. Typical numbers, a healthy prostate range is, and what connotates, okay, there's an issue here.
So you want me to answer?
Please.
Okay. Mm-hmm. So in terms of the PSA test, you're looking at a range of 4 and below is what's considered normal, but the PSA has always been more of an arbitrary cutoff number using the 4. You need to look at PSA density. You need to take the number of the PSA, but look relative to the man's age and to the size of his prostate gland. An individual with a very, very large prostate gland could have a higher PSA value that may necessarily be normal. It doesn't mean it's elevated and it's higher. So you've got to do the right type of PSA test. And there are a lot of different types of those, and the PSA density happens to be one of the more useful ones. And then once you see the elevated PSA and you're suspicious of something, the key is to get the advanced imaging, get the right MRI examination done, because a lot of people have an elevated PSA from infection, again, because they have an enlarged prostate or other conditions that can cause the elevation, which could just be temporary. So they don't need to run, you don't want to have someone do a biopsy, risk getting a severe infection if they don't need to.
Mm-hmm. And sometimes that can be the result of that test, right? That infection that you've mentioned. Looking for some questions. One of the questions is, Dr. Sperling, can the laser prostate tumor treatment be used on a patient after radiation treatment where a recurrence of prostate cancer has occurred?
Yes, so absolutely. That's one of the methods that we use. A lot of times there's two ways you can use a laser. You can go through what we call the perineum. It's the tissue between the scrotum and the rectum. And it's in men who've had radiation, we will a lot of times use that route because the rectal tissue, the rectum is damaged from the radiation. So to be safe, we try to avoid going through that rectal route. But yes, you can use the laser ablation in those cases where it's come back.
Mm-hmm. Again, how do we reach you, Dr. Sperling? What is the best way to reach out to you?
So on our website, sperlingprostatecenter.com. That's the easiest way to reach us. We also have another website, sperlingmedicalgroup.com. That's S like Sam, P like Peter, ERLING, prostatecenter.com. You can also reach us at 561-300-1350.
561-300.
1350.
1350. We have some extra time. I wanted to bring my husband in for just a moment. I don't know if you can see it on your phone, George, and we can pull you in that way. But George, if you're on your phone still, I wanted him to come on, and it's basically because of one thing. For him, prostate cancer was in our horizon. He had presented to Dr. Abraham Woods with particularly high numbers. And he was, let's turn on the light, honey, because, okay, I thought he was going to be on his, not that bright, but well, no, maybe that was good. That was good. It's fine. So I wanted you to be able to, maybe you can sit there for just a second. George, come over and sit right next to me. And I want you to look in the face of a gentleman over 60, but he was in his 50s when he got his first high number PSA. And then come over, honey. I'm not going to bite, and I did take a shower. I put on some perfume too, just for all you men. But he would. I'm using him as my real life person because I think it's that important to do it. And yeah, it's putting our business out there, but we're going to help somebody tonight, honey.
Absolutely.
He just wouldn't. He would not do what Dr. Woods said. And what was your fear?
The fear of the entire medical process.
Can you hear him?
Everything.
Can you hear him?
Mm-hmm.
Okay.
Yeah, the total fear of the entire medical process.
Mm-hmm.
As a matter of fact, it was so bad that Dr. Woods wrote so many pages
of notes on him.
Notes about me, about my phobias and fears, and just the entire process. It was absolutely foreign to me.
Mm-hmm.
But it's necessary. It is necessary to save your life.
Mm-hmm.
Without these gentlemen, I wouldn't be here.
Mm-hmm.
I wouldn't be, or if I would be here, it would be, I would be fighting probably bladder cancer right now and metastasized throughout my entire system.
Mm-hmm.
So, but
what would you say then, gentlemen, you as well, to men who do present with high numbers but do have that fear? How do you get them? Because Dr. Woods, we went to appointment after appointment after appointment.
yes, we did.
And we could not convince George to do the next thing. And the next thing would have been what, Dr. Woods?
But Monica, remember, appointment after appointment was staging because we knew we needed to help him. I couldn't put a bazooka up to his head, so we had to develop a love affair of trust. And so each appointment, there was a tasking and an asking. And remember, one of those appointments, I gave him a gift to say, here, do this while we kind of let the dust settle. You know what I mean? Mm-hmm. And my thing about it is, the doctors would agree with me. Sometimes when you're treating the sick patient, you can't just throw all the medication and stuff at them at one time. Everybody has to be treated differently. George had a different problem. He knew he was in the right place, but there were some issues dealing with phobias. And therefore, I had to say, George, I need to send you to another place so you'll learn how to deal with me and what we need to do to go forward. And so as you did that, I congratulated you. And then when you came back on the last visit, because I knew, okay, George is going to tell me his phobia, his fears, I'd already made the contact with Dr. Sperling's office to say, this is where you're going. All right, because I know you had an MRI before, it didn't hurt you. And so I said, well, Sperling can do this MRI and do this treatment, and you won't even know. Mm-hmm. And so that type of relationship, we played down your stress, because stress can kill you. Dr. Selye from Vienna has done so much research on what stress will do and how it can cause cancers to grow. So we had to play that down. So that was part of your treatment, George. Mm-hmm. You know, we just had to make it up just for you.
Yes. When 19, my PSA levels were high as 19. It's 1.2 right now. I mean, this is within 6 months. From 19 PSA level,
yes,
1.2.
So for the men who are with us in the audience, if you have a good woman by your side,
amen,
she is going to, or your mom or your sister, it doesn't have to be your woman or your wife. So all I can say is, by that last appointment, I said to him one morning, now I would get up every morning at 3:00 to be on the radio, and he would walk me to my car, we would pray. But this one morning I said, I'm not going back to see Dr. Woods anymore. We got to get an answer, and it has to come. And that was the day, that Dr. Woods said, there's nothing else here. Go see Dr. Danny. So what I think the reason I wanted you to be on, and thank you, because George doesn't like all that public speaking and everything, but you did good, dear. You did good. But the biggest thing, gentlemen, and that was why Center for Change and Florida Department of Health wanted to do this. Know your risk factors. Make sure that early detection is a part of your plan. 45 and up, you need to be checked for colorectal cancer. You need to be checked for prostate cancer, 45 to 50. Know your family history. That's also very important. George didn't have a family history of prostate cancer. But just know it. What about men that don't know their dads? That still is an issue that happens in our culture. You still need to take it upon yourself to go see a doctor. I can't afford to. Yes, you can. You find projects like Center for Change, or you make friends with a Dr. Abe Woods or Dr. Danny Sperling. Dr. Danny, before we leave, you mentioned that you're working on a new research study, and you're going to be offering these free services. Share that information with us, because brothers will be driving down the Del Rey. It's a beautiful area.
It's gorgeous.
Ooh, it's beautiful.
Nothing but money.
It's a beautiful. No, we're doing, so it's what we're doing is we're trying to show that with just like with women, we get a mammogram once a year without having to do anything invasive, no injection, no IV. We can do a 20-minute MRI of the prostate gland and evaluate for prostate cancer in men as they're above a certain age, and they're concerned about their health, or maybe they have a family history. It really can be done for pretty much anyone as a screening exam. So that's what we're going to do for a limited amount of time now, for about 100 people for the study in which we're enrolling them.
And you see Dr. Sperling's information in the chat box. Gentlemen, we're going to wrap up. We've had a lot of information, a lot of good questions. This says, I don't want to sound like the devil's advocate, but men have to stop relying on others. We have to change the culture that men have to take charge of our own health. And that is so very true. We can't be forced into a process. You have to want to be healthy. healthy. You have to, like Dr. Wood said, you have to eat better, you got to do better. But forums like this help you know better. And when you know better, you should be able to do better. Best advice for good men's health: get you a good woman, they'll make you stay healthy. One person put in, I was a 12. I'm not even going to share his name, but his score was a 12. You know, all I can say is it's important to take your health serious. Put better foods in your mouth. I took a 40-minute walk today, and that was the first time I had walked in a while. I used to walk often. That was why I got my little $50 Chuck dog. It started raining, that turned me around, but I still had 40 minutes of a walk. If you can put some type of movement into your routine every day, if you can stay away from grapes, damn, who knew that grapes were no good for you? But if you can stay away from high fructose foods, carbohydrates, things that I love, things that you love, we have to do better because we want to be around for each other. This is very, very, very important. Center for Change information is C4C. I'm going to put their information up as I go back to my last page of notes to just read this information to you one last time. Gentlemen, everyone on this call this evening, please meet me over at Barnett Park this Saturday, 10 a.m. to 12. Center for Change, along with the Caribbean Health Summit. We will be there. You'll pick up your toolkit at that time. You'll also be treated to a free prostate exam, COVID exam as well, and an HIV test. That's a very, very, very important too, to know your status. They have a toolkit for every individual. It is the 17th annual Caribbean Health Summit to provide PSA screenings for everyone. And there are 2 additional webinars that the Center for Change will be offering. And one is on medication adherence. The second is on living with a chronic disease. And also, speaking of the Caribbean Health Summit celebrating their 17th annual event, they invite you to join their virtual COVID-19 community conference, and that is this Friday, September 25th. And you can go to their website, which is cmwp.org. If there are no other questions, blessings to everyone. Thanks, Monica, for having this discussion. It wasn't really on me. It was on these gentlemen here. Thank you, doctors. Thank you, Center for Change. Thank you, CMWP as well. Dr. Sperling, thank you very much for spending the evening with us. Dr. Abraham Woods, I love you dearly. Thank you very, very, very much. Christopher Scott had another event that he had to go and host as a Zoom call. Dr. Baker, thank you so very much. I think I need to schedule my next appointment with you coming up soon, but that's on a personal note. Anyhow, this is my tribe of doctors. I wanted to introduce them to my tribe of men, my community. I love you guys. You know that. And there's nothing that can change that. As long as I have breath, I'm going to talk. That's one thing I can say about myself. And I just try to get people to love on themselves by giving them the right information. Thank you, everyone. Have a wonderful evening. Continue to watch the information that will flow to you from the Center for Change, flcenterforchange.org. Center for Change phone number 407-271-4452 for any further questions. Good evening, everyone. Thank you so much for being with us. Good night.
Good night. Thank you, doctors.